So hi everyone, very good afternoon to all my dear students. And yes, although we have done a recall on the day of the exam itself, but yes, let's quickly look at all the questions together once again for everyone. And it'll be nice if all of you can answer in the chat box and later let me know what is your score in Obs and Gynae. Okay, but overall, did you find Obs and Gynae doable in the paper? I think we did not have any question which is unique, but yes, sometimes definitely we do get confused in the options. So I'm going to help you out with figuring out what's the best answer in the given questions. So let us look at the first one. So which of the following is not used in postpartum hemorrhage? Yes, is that the correct recall? Okay, so is not used in PPH. So the answer is going to be dinoprostone. Yes, please remember dinoprostone is PGE2, right? And when we talk about PGE2, it is definitely not used in postpartum hemorrhage. Where do we use PGE2? We use it for induction of labor, right? We use it for induction of labor, and we can also use for MTP in second trimester. Okay, but we do not use it for postpartum hemorrhage. We do not use it for prevention. We don't use it for treatment. So it doesn't matter whether they gave treatment or not. Okay, it is not used in prevention, which is AMTSL. It is also not used in management. Please, PGF2 alpha is definitely used in the management of postpartum hemorrhage beta. Okay, it is not used in AMTSL, but it is used in management. When you say dinoprostone, it is PGE2. PGF2 alpha का दूसरा नाम क्या होता है? That is dinoprost. Okay, so that is dinoprost, also called as carboprost, also called as hemabate. Okay, so this is something we do use. Okay, definitely PGF2 alpha, please remember, which is carboprost. It is an important drug even for your NEET PG. So remember, it is used in treatment of PPH, but it is not used in AMTSL. Jaldi se batao, what is the contraindication? I'm sure you all will remember asthma, right? Don't use it in asthma. And please remember, when we talk about misoprostol, do not get confused. It is PGE1. Okay? And remember other questions that NEET PG is also going to ask you. So when we say carboprost, kaun batayega what is the maximum dose we use in PPH? So the maximum dose is 2 milligrams in 1 day. It is dose kitna hota hai batao? 0.25 milligrams. And it is given as an intramuscular injection. Okay, everybody is clear on this one? No doubts now? Okay, remember oxytocin remains as the drug of choice for PPH, whether it is prevention, whether it is treatment. Okay, perfect. No, 100 आप फिर से confuse हो रहे हो बेटा. That is a separate drug. That is carbetocin. It is a different drug altogether. Carbetocin is an oxytocin analog. ठीक है? And that is used in AMTSL. Uska dose tha 100 micrograms slow IV over 1 minute or 60 seconds. So these are all different drugs. Please don't get confused. Okay? Chalo, are we ready for the next question? So let me see what did you answer for this one. So this question says your patient presents with ascites and omental caking, right? Now मुझे सबसे पहले आप सभी बच्चे, because I have to teach you the approach also, right? So that we improve for next on. So can you tell me, the moment we say there is an ovarian tumor, right? Adnexal mass hai, and the moment I say there is an adnexal mass, ascites, omental caking, is it early stage cancer or late stage? It is an advanced stage cancer. So if you see big ascites, if you see omental caking, it means there are deposits on the peritoneum. So this is a advanced stage cancer. There are solid components and there are cystic components. Some students said, ma'am, wo cystic tha, isliye humne answer kuch aur mark kiya, right? So we'll come to that. Then we are saying CA 125 is also raised, and I think in this question the age group was around somewhere in the range of 60 years approximately, right? So age group dekho, CA 125 is a tumor marker for what? It is a tumor marker for epithelial ovarian tumors. So once we say epithelial, fibrothecomas are out. Yes, they are sex cord stromal tumors. Unka tumor marker CA 125 nahi hai. Then the answer is not even mucinous. Please remember, although mucinous is an epithelial ovarian tumor, magar mucinous ka tumor marker hota hai CEA, carcinoembryonic antigen. Apart from that, CA 199 is also a tumor marker. So even if there are some cystic components, you can't answer it as mucinous ovarian tumor, right? The answer to this question is serous ovarian tumor. Okay, anybody has any doubts in this question? Please let me know so that I can help you, so that we don't make mistakes in the next exam as well. Okay, so please remember this. Do not confuse this question with pseudomyx or with pseudomyxoma peritoniae. ठीक है, mucinous tumors में what is the association? The association is pseudomyxoma peritoniae, है ना? Okay, now who is going to tell me Meigs में कौन से हमने बताए थे tumors? With Meigs syndrome there has to be a benign tumor. Okay, it has to be a benign ovarian tumor with ascites and with pleural effusion. And what were the tumors that we have talked about in Meigs? Yes, so in Meigs it is supposed to be fibroma, but it can also be thecoma, it can also be Brenner's, and it can also be granulosa. Okay? All these four are Meigs syndrome. But what is the single best answer for Meigs? It is a fibroma. Shabash. Okay. Yes, somebody is saying ultrasound suggestive of multiloculated. It is okay. The answer won't change, beta. Even if they say multiloculated, the answer will not change. Please remember, serous tumors are also going to be multiloculated and they will have solid components. Okay, so even if it said multiloculated, the answer remains the same. It is not mucinous. CA 125 is not a tumor marker for mucinous tumors. Okay, bache, please remember this. Also, advanced stage cancers are mostly seen with serous. Mucinous to early pickup ho jate hain. Also, somebody is saying the question mentioned bilateral. Yes, so serous tumors tend to be bilateral. So the answer will remain as serous. Okay, are doubts cleared for everyone? Let's go on to the next question and let us say, what did you mark? So which of the following is included in the Rotterdam's criteria? So what is the answer? Do we include obesity? Yes or no? No. Obesity is not included. Do we include hirsutism? Yes. Do we include irregular cycles? Yes, because they are a marker of anovulation. Yes, so they're a marker of anovulation. And what do you come across? Is it oligomenorrhea or amenorrhea? So what we come across more commonly is oligomenorrhea, followed by amenorrhea. ठीक है बच्चे? So yes, the answer is only going to be B and C. Is it clear? The answer is only B and C. So this is based on the Rotterdam's criteria where we need 2 out of 3. Can you tell me, when we talk about ultrasound criteria of Rotterdam's, who is going to, yes, even if it is written modified Rotterdam's, do you know what is the modification? I'm coming to that only. So even if we say modified Rotterdam, the only criteria which is now modified is the ultrasound criteria. So what do we include now? So now it is more than or equal to 20 follicles which are less than 10 mm in size. Earlier it was 12 follicles. Okay. So, bache, even if it said modified, it doesn't change the answer. The answer remains the same. Okay, so now it is 20 follicles instead of 12 follicles. I have given it as an update in DBT also, in the classes also, right? What is the other ultrasound criteria? Or we say ovarian volume more than 10 ml or 10 cc. Please please remember necklace pattern. Jaldi se mujhe batao, is it a criteria? No. So remember necklace pattern, or the pearls pattern, pearl of strings pattern, necklace pattern is definitely a very characteristic finding in PCOS, but it is again not included in the Rotterdam criteria. This is the other place that they will try and confuse you. Okay, everyone clear? Anybody has any doubt on this question? Okay. Yes, insulin resistance is quite common, but it is not a Rotterdam criteria. Up to 75% of women can have insulin resistance. Up to 50% of women can have obesity, but they are not included in the Rotterdam criteria. Okay. Chalo, let's look at the next one. So this is again something that we have done. So I'm sure आपने सही किया होगा. For medical termination of pregnancy, opinion of 2 doctors is required at what gestational age? Yes, 20 to 24 weeks. Okay. So up to 20 weeks, we need opinion of 1 RMP. है ना? From 20 to 24 weeks, we need opinion of 2 RMPs. Okay, what about beyond 24? Beyond 24, we need opinion of medical board. Okay, we need opinion of the medical board. Also, please remember, beyond 24, it is allowed only for gross congenital anomalies, and we will need approval of the medical board, which you all know will have a obstetrician, it will have a pediatrician and a radiologist. Okay, we don't need a lawyer for this, right? And please tell me, up to 20 weeks ka MTP is allowed for only which condition? So remember, there is a as per the MTP Act. So I am telling as per the MTP Act, which is how they specify in the exams. So as per the MTP Act, if there is a contraceptive failure, we will do MTP up to, for this it is allowed only up to 20 weeks. Okay, so as per the Act, for contraceptive failure it is up to 20 weeks. What about rape victims, beta? Who is going to tell me? For rape victims, it is up to 24 weeks. So now if I ask you, if there is a rape victim and the patient comes beyond 24 weeks, will you do MTP or not do an MTP? Batao. So if there is a rape victim who is coming to us beyond 24 weeks, would you do MTP or no? The answer is no. She has to go and file a case in the court. Okay, so for rape victims, it is only up till 24. For contraceptive failure, it is up to 20 weeks. Is this clear? Chalo. Any doubt in this question? Anybody has any doubts? You can please write them down and let me know. I will move on to the next question for all of you. So which of the following does not cause fetal bradycardia? Okay, does not cause. So what is the answer? Again, प्लीज रिमेंबर, जब मदर को फीवर होता है तो मदर का टैकीकार्डिया होता है और बेबी का भी टैकीकार्डिया होता है. सो मैटरनल फीवर इज एक्चुअली वन ऑफ द मोस्ट कॉमन कॉजेज ऑफ फीटल टैकीकार्डिया. Okay, it does not cause bradycardia. Fetal head compression, yes. Can you tell me which type of deceleration will you see with head compression? So with head compression, it is early deceleration. Yes, it is early deceleration. Placental abruption, yes, we all know causes fetal distress or bradycardia. Congenital heart block, beta heart block hai to bradycardia to hoga hi, theek hai? So the answer for this question is maternal fever. Okay, quickly tell me, when we talk about variable decelerations, what is the reason for this? The reason for variable decelerations is cord compression, yes. And what about late decelerations? What about late? So for late decelerations, the reason is uteroplacental insufficiency. Okay, uteroplacental insufficiency. They can also say fetal hypoxia, right? And what about sinusoidal pattern? So remember, the reason for sinusoidal pattern is severe fetal anemia. In which conditions will you see this? Like RH incompatibility, like vasa previa, okay? Like vasa previa and RH incompatibility. Okay, good to go everyone. Any doubt in this question? Okay, so then we will move on to the next one and you will tell me what is the answer for this question. So they had asked to arrange the steps of a pap smear. So what is the first thing that you're going to do? You're going to put the woman in a lithotomy position. Then you will do a per speculum examination. And then do you do a PV or no? The answer is no. Please remember, we are not going to do a PV examination before taking the sample for pap smear. This is something I teach even in my routine classes, because if you do a a PV exam, you're going to remove the cells of the on the transformation zone. So the pickup rate could be less. Also, sometimes when you do a PV, you put a jelly. You're not supposed to put any jellies before you take the sample. So you take the sample. If you want to do a PV exam, you will take the sample after, you will do the PV after taking the sample. Is that clear to everyone? Yes, so please remember, PV karna hai, to after you have taken the sample. Another question I want to ask you. Suppose you're going to use both the Ayer's spatula and the endocervical brush. Which one are you going to use first? Can you tell me? Which sample will you take first? Will you take the sample with the endocervical brush first, or will you take it with the Ayer's spatula first? So always we will first take the sample from the ectocervix. So we will use the Ayer's spatula first. Okay. We use this first and make the slide. Okay. Then we will put the brush into the endocervix. So this is done after taking the sample from the transformation zone. Yes, so pehle ecto, phir endo. Because if you do it from the endocervix first, it can cause bleeding and that can again cause alteration of the sample. Okay, quickly 2 more MCQs. Can you tell me, do you do any air drying when you take pap smear? No. So please remember, there is no air drying. You have to put the slide immediately into the fixative. And fixative bhi yaad rakhna, 95% ethyl alcohol is what we use more commonly, but we can use a combination of alcohol and ether as well. Okay. Also, please remember, do we make only one slide or 2 different slides? Suppose Ayer's spatula hai, endocervical brush hai. So both go on the same slide or different slides? The sample goes on the same slide. Okay. We don't use 2 slides, right? Is that clear to everybody? Any doubt in this question? Otherwise, I will move forward. Let me know if you have any doubt in this one. Okay. Now, okay, this XV is written here by mistake. Okay. Now tell me. So minimum age for MTP. I don't know why have you done this wrong. It should not be. It is a very basic question and some of the people in the other platforms are also giving you wrong answers. So be very careful when you follow answers on YouTube. Okay. So when we say minimum age for MTP, as per the MTP Act, there is no minimum age. So answer in this question is 16 years. That is why we teach you routinely in class that if a minor girl comes to you for MTP, can you do the MTP or not? Of course you can do. And who is a minor girl? A girl who is less than 18 years of age. So if a minor girl comes to you for MTP, can we do it? Of course, yes. The only thing is we will not take consent from the girl. We have to take consent from the legal guardian. Okay? No, 18 is wrong. I don't know who, maybe they are not obstetricians. Okay? And maybe they've never practiced. And maybe they don't understand what the question is asking. So please remember, there is no minimum age for MTP. If the girl is, no, why not? This is ideally, these questions can't be given. Why? This is something that you will come across in your daily practice. What will you do then? So these are very basic things. INICET is actually asking you basics and they are trying to see whether you have just mugged up the content or you are, you understand what you are learning. So what will you do? Tell me, Sairam, if a girl who is 14-year-old, she's a rape victim, she comes to you, you will say, I will not do MTP. Of course you will do, right? The only difference is that you will take consent from the legal guardian. That's the only thing. Is that clear to everyone? So there is no minimum age. Jo bhi minimum hoga, wo answer hoga. If this question had an option of 14, we will go with 14. Do you understand this? Yes? Of course, yes. The answer is 16 years. There is no minimum age. You can do MTP. You will just have to take consent from the guardian, not from the girl herself. All right? Okay. Do you take consent of, in cases she is not a minor, okay? Let's say she is more than 18 years old. Whose consent will you take? The girl herself or the girl and the husband? Only the girl. So consent of only the girl is mandatory. Okay, please remember, okay, there is nothing like consent from the spouse, which is not mandatory. For MTP, consent of spouse is not mandatory. Is that clear? Okay, is that clear? Yes, she may have been sent because of the hospital policies, but that doesn't mean that we will not do an MTP. Okay, is that clear? So please remember, MTP is an important topic. You should know this. As per the MTP Act, there is no minimum age group. Okay, so remember, if she is less than 18, you take consent from the legal guardian. If she is more than 18 years, you take it from the girl herself. Okay, chalo. All right, so what are the correct timings for intrauterine device? Okay, so can we put it immediate postpartum? Yes, we can. So this is also called as post-placental. So post-placental is when you insert it within 10 minutes of placental expulsion. Okay, now, so somebody is saying if she is mentally unwell, whose consent? Again, the legal guardian. So if girl is mentally unwell or unfit to give the consent, then again you take consent from the legal guardian. Okay. Can we do it up to 48 hours postpartum? Yes. This is what is called as postpartum IUD. Pehle wale ka naam hai post-placental. Okay, so this is called as post-placental. Dusra wala hai postpartum. Can you put it within 7 days of the menstrual cycle? Yes, because we are quite sure that in the first 7 days, she is not in her fertile phase and she is unlikely to be pregnant. So the ideal time in the menstrual cycle is within first 7 days. Okay, so ideal time is within 7 days of LMP, yes, which is the first 7 days. Can I put it 5 to 7 days before the next cycle? No, because then we are not sure that the woman is pregnant or not. There is a possibility. So what will we include? We will include A, B and C. It was a multiple completion type question. So we will include A, B and C. Okay. All right, then somebody is saying why not during menses? The chances of infection are higher. So you don't want to, put it while she is menstruating. So you wait. It's not a contraindication, but we want to wait for menstrual bleeding to stop. Otherwise, we can put it anywhere in the first 7 days. See, the guidelines say you can put it any time in the menstrual cycle as long as you are sure that the woman is not pregnant, right? So we can put it any time in the menstrual cycle provided we are sure that she is not pregnant, right? So the ideal time for this is in the first 7 days of the menstrual cycle, because day 1 of LMP is day 1 of the menstrual cycle. Is that clear? So D is not the best option to be included here because we are not sure if she is pregnant or not. She is crossed that phase and therefore we don't want to insert a IUD. Is that clear? Okay, perfect. Let's go on to the next one now. So let's look at this. So a 31-year-old woman who has come to us with infertility. So one hint in the MCQ is infertility. Then delayed menses, okay, which we could take as irregular menses. Laparoscopy pe likha tha, the uterus is normal and chromoperturbation shows a free spill. Can you tell me what does this mean? So if we say it shows a free spill, it means the fallopian tubes are normal. They are patent. So uterus is normal, the fallopian tubes are patent, and they had shown you an image with enlarged ovaries. So this is the best picture that I could get closest. Okay, so all these go in the favor of what? Yes, polycystic ovarian disease. Now, some of you, would ask me, why not a tubo-ovarian mass? So, number one, if there is a tubo-ovarian mass, unlikely that you will see a free spill, okay? The HSG or laparoscopy will show you those findings. Endometriosis is in endometriosis, you are likely to see a lot of adhesions in the pelvis. Also, the cyst in the ovary will be chocolate colored cyst. It would be a discoloration in the ovary that you will see. Ovarian cyst. Ovarian cyst, number one, will not cause both ovaries to be enlarged. Ovarian cysts are not necessarily associated with irregular cycles or with infertility. Follicular cyst of the ovary is very, very common. Okay, it's very common, but it is usually unilateral. It doesn't cause a very enlarged ovary. It does not cause irregular cycles as such, okay, or infertility as such. So with the clinical scenario and enlarged ovaries, it is going to be PCOS. I had given the same image-based question on my Instagram series for MCQ, so go check it out, okay? I gave it in January as well. So the answer is polycystic ovarian disease, okay? Chalo, let's go on to the next one. Now, again, a place where I am seeing wrong answers being circulated. So, which of the following is not a benefit of using MagSelf? बहुत बार आप लोगों को पढ़ाया है, हर क्लास में, हर रिविजन सेशन में पढ़ाया है. Please remember, when we talk about MagSelf, if there is oliguria or if there is a kidney disease, MagSelf is not to be given, or we have to reduce the dose. MagSelf will never improve renal blood flow. It can improve cerebral blood flow because the mechanism of action is in the brain itself. It does cause cerebral vasodilatation, but it does not increase renal blood flow. In fact, we have taught you that if there is oliguria, yes, can you tell me, if there is oliguria in your patient, do you give MagSelf or you don't give MagSelf? So our criteria was less than 30 ml per hour or less than 100 ml in 4 hours. Then we do not give the maintenance dose of MagSelf. Do you remember this? Yes or no? Yes, so we will not give the maintenance dose because your maintenance dose will cause toxicity. Please understand, when it comes to the loading dose, can we give the loading dose? Yes. So loading dose of MagSelf has to be given irrespective of renal function. It is the maintenance dose which we will alter or which we will stop. Is that clear? Now also, some of the places are giving you wrong answer as decreases risk of placental perfusion, abruption. Is this statement true? Yes, it is a true statement. There is an entire trial based on which MagSelf is given as the drug of choice. It is called as the MAGPIE trial, which is what we use in obstetrics. And it clearly shows that giving MagSelf reduces the risk of placental abruption. It also reduces maternal mortality. It also reduces the probability of developing seizures. This is why you give it as seizure prophylaxis. Do you understand this? Okay, are you clear on this? Yes, so please remember, this is a true statement. MagSelf does reduce the risk of placental abruption. It does reduce the incidence of seizures. This is why you give it in impending eclampsia. Do you remember? I have taught you, when you get a question on impending eclampsia and when we ask you next step, can you tell me what is the answer? The answer is give MagSelf because you want to prevent the seizure, right? So next step is give MagSelf, but yes, along with MagSelf, later you will also give antihypertensives, and once you have stabilized the patient, you will also deliver the woman, right? But that is after stabilization. Is that clear to everyone? Okay. So answer here is improve renal blood flow. Okay. Now, what about neuroprotection? Yes, MagSelf is used for fetal neuroprotection. Can you tell me when do we give it? We give it if the POG is less than 32 weeks, because by 32 weeks the brain of the baby is neurologically mature. So you only give it for neuroprotection if the POG is less than 32 weeks. Also remember, it is a weak tocolytic. It is definitely a tocolytic. Yes, so it can increase the chances of PPH, but the benefits of giving the drug outweigh the risks. So therefore we use Maxulf in preeclampsia and eclampsia, right? So it is a weak tocolytic. Is that clear to everyone? And when you give Maxulf, do you know that the fetal heart rate may also show a dip? Do you know this? I want everyone to know this. When you are giving Maxulf to the mother, yes, it will also cause a slight dip in the fetal heart rate, and it is not an indication for cesarean. You have to know that Maxulf is crossing the placenta, it reaches the baby, it can cause a dip in the fetal heart rate, but this heart rate will recover, right? So at the time of giving Maxulf, if you come across a dip in the fetal heart rate, it is not an indication for cesarean. Because as I said, the heart rate will recover in next 15 minutes. But please remember this, if fetal heart rate shows a persistent dip, okay, if it shows a persistent dip beyond 15 minutes of Maxulf, then yes, you should think of probably abruption or some other complication, and then it may become an indication for emergency cesarean, right? But majority of times the heart rate will recover within 15 minutes. Is this clear? Okay, perfect. No, you will only give it when you are anticipating a delivery before 32. Why will you give it to all pregnant women? You give it for neuroprotection when you think that the woman might have to be delivered before 32 weeks and then the baby's brain is not mature. So in that case, yes, you want to do the maturation, okay, fetal neuro or protection of the baby's brain from cerebral palsy, okay? Chalo. Let's look at this one. So which of the following statements are true regarding the shown findings? So exact image that we do in the class as well. So these are Kohl-Exner bodies, rosette shaped. In fact, they had also shown an enlarged image of coffee bean nucleus, right? So like this. So coffee bean nucleus was there, rosette arrangement, Kohl-Exner bodies were there. So what is this? Yes, it is a granulosa cell tumor. In all classes that I have taken this year, I've said your exams are asking something or the other about granulosa cell tumors, so you better know about it, okay? And it is, again, I'm saying it again, it is likely to come in NEET PG as well. So go back to your notes and see that you're covering every point of granulosa cell tumors. Yes. So is it a sex cord stromal tumor? That's a true statement. Kohl-Exner bodies were shown. That is also true. The tumor marker is inhibin, not CA125. I've told you CA125 is a tumor marker for epithelial tumors. Here it is inhibin, and to be very precise, inhibin B is a beta marker. Okay. Also, please remember, granulosa cell tumors are estrogen producing tumors. So can you tell me which other investigation should you do in a woman who has granulosa cell tumor? Which other investigation? We should always do a endometrial sampling or an endometrial biopsy. Always do it, because these women are at higher risk of developing endometrial hyperplasia, endometrial cancer as well. So another cancer which can coexist at the same time in these women is endometrial cancer. Okay, somebody is asking, can it cause precocious puberty? Yes, but granulosa cell tumors are more common in perimenopausal women. They are not common tumors in younger age group. They can happen. Can you tell me which is the most common ovarian tumor in younger age group, like 10 to 30 years? then you have to know that these are germ cell tumors. So if we ask you which ovarian tumors are likely to cause precocious puberty, what will be the better answer? Will it be germ cell or granulosa? So granulosa can cause precocious puberty, but they are not the best answers. So the best answer for precocious puberty will actually be germ cell. Okay? Granulosa can also cause, but they are not the answers. Okay, so it can also cause precocious puberty, but the best answer for precocious puberty is which ovarian tumors? They are germ cell tumors. Is this clear to everyone? Okay, perfect. Let's go on to the next question. Again, I have always said that, NEET PG and INICET both are fond of asking about Turners. The difference is INICET will go into details, right? So which of the following is false about Turner syndrome? And it is webbed neck. Okay, I have in my classes specially talked about short fourth metacarpal. Yes, and it is very characteristic to Turner's. Can you tell me what is characteristic of Down syndrome? Short fifth distal phalanx, right? So that is Down syndrome. Short fourth metacarpal is Turner's. Widely spaced nipples and shield-shaped chest are again very characteristic of Turner syndrome. Webbed neck, again characteristic, along with low posterior hairline. I'm again telling you it is again a probable topic for your NEET PG. So go back to my notes, revise every little detail that I've given about Turner syndrome. Yes, the answer is prominent occiput. Very good. Now quickly tell me, will you do a gonadectomy in Turner syndrome? Yes or no? Jaldi jaldi batao. So please remember, no gonadectomy in Turner syndrome. What treatment will you give? You will have to give HRT, hormone replacement therapy, to Turner's, and it will be a E+P type of HRT. Is that clear? Also remember, Turner syndrome have high risk of diabetes, mellitus and Hashimoto's. Okay, so diabetes and Hashimoto's high risk hota hai. Bicuspid aortic valve is the most common cardiovascular finding. Okay, yes, there can be coarctation, but best is bicuspid aortic valve. Also remember, they are very likely to have horseshoe kidney. Okay, horseshoe kidney. Can they have hearing loss? Yes, they can have both sensory neural as well as conductive hearing loss. Can they have inflammatory bowel disease? Yes, but usually they will not have SLE, which is the last year's question in INICET. So every time they ask something about Turner's. Okay, so SLE nahi milta hai. Remember, IQ is absolutely normal in Turner's. They have a slightly short lifespan, and I am sure everyone knows about the karyotype, right? 45XO. You have to know LH, FSH levels are high. Okay, the estrogen levels are low, and this is why we call it as hypergonadotropic hypogonadism. Okay, so these are other important points that everyone should know. Should I move on to the next question? Let's look at the next question. Again, a wrong answer being circulated in the recalls for this question. So your patient is a primea gravida. She is 8 weeks pregnant and she is diagnosed with asymptomatic bacteriuria. I think in the question they did give a colony count of 10 to the power 4 as well as E. coli. And they said the repeat sample also shows this. So what is the most common complication if this is left untreated? So please remember, these were the correct options. Pyelonephritis was not in the options. These options are made by some recall people on their own. The options were miscarriage, chorioamnionitis, preterm labor and neonatal mortality, and the answer is preterm labor. Yes, there is risk of neonatal mortality as well. There is risk of low birth weight baby as well. But the most common one associated with infections is preterm labor. Okay. Normally, yes, we have taught when we have done physiological changes with you in the class, right? That yes, one of the reasons why we treat, so if you go back to my class notes, I have taught you like this. In physiological changes, when I have talked about asymptomatic bacteriuria, I have told you that if left untreated, there is a 25% risk of pyelonephritis, which is right. Okay, but pyelonephritis was not in the options in this question. It is a self-made option by some people. Okay, it was not in the options, and therefore the answer to this question remains as preterm labor. I have taught again in the topic of preterm labor that one of the important risk factors is previous history of preterm labor and infections. So in fact, be careful. You can get it in NEET PG as well. Suppose they tell you a pregnant woman has bacterial vaginosis, okay, and she is symptomatic. What can happen to her? Can you tell me? Again, the answer is preterm labor. So NEET PG can again give you this question, but in terms of bacterial vaginosis. And this is why we say that if there is bacterial vaginosis and if it is symptomatic, we will treat. And the drug of choice in pregnancy remains as metronidazole. Is that clear to everybody? Remains as metronidazole even in pregnancy for bacterial vaginosis. So asymptomatic bacteriuria, even if it is asymptomatic, we have to treat because it will increase the risk. Okay. Now somebody was asking me, ma'am, miscarriage. No, urinary infections don't cause abortions. When we say infections causing abortions, they are Torch group of infections or other congenital infections. UTIs usually do not cause abortions, beta. Is that clear? Okay. Any doubt in this question, or else I will move on to the next one. Let's look at the next question. So this is probably the easiest question in the entire section. Most common HPV strains associated with cervical cancer. So we know it is 16 and 18. 16 and 18 are together responsible for 70% of all cervical cancers. Okay. In dono mein se bhi, can you tell me which is the single most common? The single most common among these two is type 16, which is responsible for 50% of all cancers. Now, what are you likely to get in NEET PG? Again, a simple question. Can you tell me HPV 16 knocks out which gene host ka? It acts on which host gene? Can you tell me? So 16 mein there is, when we talk about these, which host genes are they going to affect? Batao. So there is a, let me see, yes, 18, yes, you are right. 18 is more likely to be associated with adenocarcinoma, and 16 will usually cause squamous cell cancer, which is actually the most common cancer. So yes, when it comes to host genes, remember E6 and E7. So E6 kisko affect karta hai? P53, and E7 will affect the retinoblastoma gene. Okay, so E6 is P53, E7 is RB gene, and they are both examples of what? Tumor suppressor genes. Yes, they are both examples of tumor suppressor genes. Please remember, E6 and E7 are required for malignant transformation, okay, of the cell, right? So for malignant transformation of the cell, it is E6 and E7. If you have to mark one of them, the answer will be E7. Single best answer is E7, but otherwise both are required for malignant transformation. Okay, can you tell me what is the most common site for adenocarcinoma of cervix? What is the most common site for adenocarcinoma of cervix? Can you tell me? Now, this is again a common mistake you're likely to do. They have specified adenocarcinoma, then the answer will be endocervix. But if I remove the word adenocarcinoma, I just say most common site of cervical cancer, then yes, it is the transformation zone, also called as the squamocolumnar junction. But when we see, again you're doing the same mistake, when we mention adeno, the answer is not transformation beta G, then the answer is endocervix. Okay, chalo. Again, a very basic question, and they are testing a lot of basics. All are aneuploidies except, so aneuploidy is change in the number. Okay, so trisomy 21, yes, is an aneuploidy. 13 is an aneuploidy. Klinefelter, इस बार मैंने हर क्लास में स्पेशली क्लाइनफेल्टर सिंड्रोम पढ़ाया है. इट इज लाइकली टू कम इन नीट पीजी ऑल्सो. आई विल recommend all my students to go back and see the comparative tables that I have done for Klinefelter's and Turner's syndrome. I've covered it in DVT as well. Please do Klinefelter's and Turner's, revise them, they are important. Yes, so the answer is Bloom syndrome. Okay, Klinefelter के लिए, can you tell me the keywords, because I want everyone who is listening to me should benefit. So please remember, they have primary hypogonadism. So again, the LH and FSH levels will be high. It is hypergonadotropic. Okay, and please remember, they have a small and firm testes. There is no spermatogenesis. Okay, and as a result, what is the finding in the semen analysis? It is, yes, they will have azoospermia. Okay, do they have a Barr body? Yes, so we say they are false positive Barr body, right? Normally males are not supposed to have a Barr body, but in this case, yes. Yes, very important, Gautam. Good. The other key features of Klinefelter will be tall stature. Usme bhi na beta, please remember, they have tall limbs, hands and legs. वो tall होते हैं, long होते हैं मतलब. So tall stature, gynecomastia, and apart from that, tremors, bone loss. Okay, muscle atrophy, muscle mass is less. ये सब are key features, okay, of Klinefelter syndrome. It is an important topic. Please see these key findings. It is likely to come in exams as well. Okay, chalo, let's go on to the next one. Which of the following is contraindicated in pregnancy? So Dr. Sumer has also covered, we have also covered, a CT scan is not to be done. Can we do MRI? Yes, but not use gadolinium contrast. We are not supposed to use a gadolinium contrast. This is ultrasound, which is in fact very commonly used. Can we use Doppler? Yes, Doppler can be used, but do we use it routinely in the first trimester? The answer is no. So Doppler is not routinely used in the first trimester. Okay, because it generates a lot of heat. So in the first trimester, it's not completely safe. But apart from first trimester, yes, you can do Doppler as many number of times as you have to do. Isme bhi pehle bhi INICET people have asked this question, which is the safest and method for early detection. Okay, safest method for early detection of cardiac activity. Do not answer it as safest and earliest also, right? So do not answer it as Doppler. The answer will remain as ultrasound, and it is M mode. Because when you say cardiac activity, it has to be detected in the first trimester, and then we routinely do not use Doppler. Doppler is not exactly safe in the first trimester. Okay? Chalo. There were I think 2 questions on valproate. You will tell me 2 थे या 1 था. एक तो यही था. Question is, which of the following medications are associated with increased risk of neural tube defects? How many of you had attended the INI marathon that we did on DAMS Daily YouTube channel? In the INICET marathon that we did, I covered only a few slides of my DVT, and most of the slides that I showed question came from it. And I showed the slide of teratogens, especially talking about valproate, and yes, it is going to cause spina bifida, right? So I talked about preeclampsia, especially there. I talked about teratogens. So yes, the answer here is valproate. Valproate, please remember, is category X. So I think there was another question, you will tell me ki tha ki nahi, but there was another MCQ probably, which said a woman is on anti-epileptics and now she is pregnant. The neurologist is thinking of changing the drugs. Which one will not be given or removed? The answer to that question, if it was there, is also valproate. Normally we say when a woman is on anti-epileptics, we say you continue the same drugs in pregnancy. The exception of the rule is valproate. If she is on valproate, yes, we want to change it because it is highly toxic to the fetus, right? So even if that question was there, then also the answer to even that question is valproate. Yes, lithium we all know is going to cause Epstein's anomaly. Now listen to me very carefully. There is a high probability in NEET PG that they will show that, you know, there is a baby born, or a newborn baby with what? A newborn baby with boot-shaped heart, right? Or different shapes of heart. So can you tell me, when it is lithium, what is the shape? It is box. So if they say a box-shaped heart, which drug did the mother receive? Then we all know it is lithium. Okay. So valproate is spina bifida. Do we give ACE inhibitors in pregnancy? No, they are absolutely contraindicated. They will cause renal agenesis or problems with the kidney development, right? So valproate nahi dena hai, ACE inhibitors nahi dena hai. Can you tell me what about endomethacin? Can you recall what about endomethacin? So endomethacin should not be given beyond 32 weeks. It will cause premature closure of ductus arteriosus, right? So do not give it beyond 32 weeks. Please remember, when we talk about warfarin, is it contraindicated in pregnancy? Yes, warfarin is contraindicated in pregnancy. It is also category X. There is only one condition for which warfarin is allowed, only one in pregnancy, and that is prosthetic heart valves. Okay, so warfarin is only allowed for one condition, and that is a woman with prosthetic heart valves. Please remember, other than that, whenever we talk about anticoagulant in pregnancy, suppose a woman develops deep vein thrombosis and you have to give anticoagulant, which one will you give? So for everything else, you will stick to low molecular weight heparin, right? Only for prosthetic heart valves, yes, we are allowed to give warfarin in pregnancy because benefits outweigh the risk. Okay? Perfect. Let's look at the next or the last question. This is, competitive GnRH antagonists are used in which condition? And it was a multiple completion type question. So do we use it in advanced prostate cancer? Yes, it is directly from my class notes where I've given you uses of GnRH agonist and antags. So you can use it for prostate cancer, and yes, we use it for controlled ovarian stimulation in IVF. Typically, if we have to reduce the risk of OHSS, go back to my notes and you will see that I have specially mentioned this. In IVF cycles, when there is a higher risk of ovarian hyperstimulation syndrome, then we use GnRH antags to reduce the risk, right? So we do not use it for tocolysis, and you cannot use it for hypogonadism, right? If it is hypogonadism, you have to stimulate the gonads and not suppress them, right? So the answer will be 1 and 3. Yes, so I think those were the 18 questions, and it's always around 18 to 20 MCQs in obs and gynae in INICET, and it is about 30 MCQs in NEET PG. Okay, so if we talk about 2 sets, then it will be 30 in one and 30 in the other. So like 60 MCQs from obs and gynae. Okay, so I hope that you do well in the exams, and I wish you good luck for the results of INICET. Please remember, irrespective of what the result is, you need to know that you are, it doesn't define you. It doesn't define what you can do in future, how your next exam is going to be. So please take the result in your stride, okay? And we are there with you, especially if you feel you want to reach out. We are going to be here, me, Dr. Sumer, entire DAMS teams. Okay? Result ko, don't take it as something which is reflecting your capability or what you can achieve in future. It is just one exam. Okay? Take it in its stride, learn from it, and ensure that isse aage jo exam aa raha hai, which is NEET PG, okay, it is going to be, a much bigger opportunity for all of you, right? So let's take that as an opportunity and presume that God is giving us another chance to do well. So don't get bogged with the results. We are here to support you irrespective of what your result or rank is. You are not your rank. You are an individual with immense abilities and capacity. एक एग्जाम थोड़ा सा ऊपर नीचे हो गया, इसका मतलब ये नहीं है कि आगे भी ऐसा होगा, ठीक है? इसका मतलब ये है कि हम और मेहनत करेंगे, अपनी गलतियों से सीखेंगे और we will become better, right? So wish you good luck everyone. Yes, I am so happy if you have done all correct. I am proud of you. I am proud of each one of you irrespective of how many correct you have done, okay? I think you showed up in the exam, you did your best in the exam, and that's what I am proud of. I am proud of the efforts you make, okay? I am proud of every time you show up as an individual. I am proud that you persist in the fight and you do not quit when things get difficult. So we are all proud of you for every little effort that you are making. So wish you good luck. Thank you so much. Take care everyone. Bye-bye.